Good. It's really a pleasure for me to be here today, and I want to thank certainly the dental school and Peter for this honor. Let me say a few words about Peter. I really do consider him to be, but they'll be nice words, Peter. I really do consider him to be an innovator and someone who's very much concerned about the future of dental education, as I guess all people in our positions are. But Peter has the, if not unique, but certainly one of the few people who's really has not been afraid to raise his voice about why this is important and to do something about it, and I certainly commend him for that. In trying to think of a good way of opening this presentation, I felt maybe it would be best if I contrasted our football teams. I told the story last night that Michael Sovereign, who was the president of Columbia University when we had our 44-game losing streak, I heard him speak at an event celebrating the 250th anniversary of the school, and Michael said, as long as the number of Nobel laureates who were educated or had some connection with Columbia exceeded the length of the losing streak, he was fine with that. I couldn't think of a more appropriate thing for the president of an Ivy League institution to say than that. But I've actually done even a little bit more homework. On October 24th, 1936, Columbia actually visited the Big House and lost 13-0. Venture to say if Columbia's team visited the Big House today, the score wouldn't be quite that level. But I will be at the game on tomorrow when we play Fordham. So that's my introduction. So this, for those of you who aren't familiar with the medical center, is the Columbia University Medical Center, which is really sort of outlined here. This is the Hudson River, so this is northern Manhattan, and this is the great state of New Jersey. And for those of you who have visited Columbia know, you can't find the dental school building, because there is no dental school building. We are, in essence, floors within the context of the Health Science Center. On our administrative floor, the floor that I'm located on, above me is the Department of Medicine, below me is pediatric endocrinology. So we have an opportunity to interact with our colleagues, mostly in medicine, but certainly also in public health and nursing, on a very regular basis. And certainly those interactions have shaped my thinking about the future of dental education, as has my educational experience, be that at Stony Brook, where as a dental student we were educated in the first 2 years with the medical students, and certainly again at Harvard. So, to begin, all professions continually seek to improve via defined planning process. For the health professions, this ultimately means improved patient care. I think we'll all agree. And our profession, as other professions, have a number of noteworthy planning reports or planning exercises, a couple of which I've listed here. First is the Institute of Medicine, Dental Education at the Crossroads, and that's where I've taken my title from. That was published in 1995. I think it's a fascinating document, and I don't think, however, that much of what's in that document has truly been implemented, but I think many parts of it are very, very relevant today. The American Dental Association did its own planning document, The Future of Dentistry, that was published in 2001, and then more recently, our Educational Association, ADEA, published Beyond the Crossroads, and I actually didn't know that they had also used that title when I chose mine, and that was in 2009. This is the Commission on Change and Innovation. But as we began to develop this theme, and I certainly want your feedback as time, as soon as I conclude, let's talk a little bit about the definition of the ADA, or definition of dentistry, as defined by the ADA in 1997. It's the evaluation, diagnosis, prevention, and/or treatment of diseases, disorders, and conditions of the oral cavity, maxillofacial area, and/or the adjacent and associated structures and their impact on the human body, provided by a dentist within the scope of his or her education, training, and experience. I think it's a pretty broad definition. I think we need to think broadly about how we define the profession going forward. So the question really is for us, in terms of the dental profession, where do we fit in the context of health care? And I think this is a question that has not been asked as often and as loudly as it should, and that's really going to be what I'm going to be speaking about today. So let's sort of lay out the environment or define the environment. And I needed to go into the literature and find this out. Much of the data I'll show you in the next few slides is from the Kaiser report on the health of states. In terms of the number of dentists in the United States, there are nearly 250,000, 233,000, and interestingly enough, 19% were female. I would have thought it was a little bit higher. Contrasting that with our physician colleagues, where there are almost 1 million, nearly 30% of physicians today are female. In terms of who we are and where do we fit, more than 80% of dentists are considered to be generalists. Here are the specialties. Orthodontics is the one that's most populated with about 5.3% of our profession, et cetera. And if you consider pediatric dentistry to be a primary health care, and general practice to be a primary health care, nearly 85% of our professions really can be considered to be primary health care providers, and I think that's important. If we look at healthcare expenditures in the year 2010, this also I found to be fascinating. In the entire US, the total was nearly $3 trillion, but if we look at here, this is hospital services, physicians, this is for medications. Dentists, it was about $124 billion, $125 billion. So I did a simple calculation. I took the number of dentists, I divided that into the amount of money that was spent on dental services, and that comes to over $500,000 per dentist. So if there are any students in this room, I think they should perhaps smile about that. We do certain things extraordinarily well. And I think we, perhaps more so than any other healthcare discipline, can recreate nature or even improve upon nature in a way that many of our other health science and medical colleagues cannot. Here's a couple of examples. I don't know if you can you see that? Can we dim the lights here? Here's a young woman who is treated by one of our faculty members. She's a very attractive young woman, but I think you'd really be drawn almost immediately to the appearance of her smile. And here's a close-up look at that. And as you can see, and as I think most of us would recognize, this is intrinsic staining due to tetracycline exposure in utero. The dentition generally is in quite good shape. She went to see one of our faculty. He placed laminates with minimal tooth removal, and suddenly she looks a whole lot different and I think a whole lot better. So I think, again, compare this to what others can achieve in terms of plastic surgery and what have you. I think we do a remarkable job. Here's another example of essentially intact dentition. You can see this tooth is discolored. Why? This tooth had undergone pulpal necrosis as a result of trauma, and now there's external resorption. So clearly this is in danger of fracture. Here's the extracted tooth, and you can see the soft tissue associated with that. An implant was placed. Implant was placed, and here's now the replacement, the restored tooth. I mean, quite remarkable what we're able to achieve. So I guess this is the dichotomy, and all of us have been thinking about this dichotomy for quite a while. The upper arrow points to our technical and mechanical skills and how important that is to our profession, and clearly it is. Whether it's new materials, procedures, technologies, just think how implantology has changed what we do and how we do it so much better today, what's available out there today. But the lower arrow, the biological side of dentistry, is the part that I'm really going to be talking more about, and whether that has to do with new diagnostic procedures, the aging of the population and how we respond to that, the relationship between oral infection and systemic disease, the increase in chronic diseases in the population. We've got to think more about this because our population, the population that's being treated, is changing. This is a quote from the ADIA document I cited earlier, and it doesn't specifically relate to what I'm talking about, but I can give you a sense of, I think, where the profession is and some of the concerns that have been raised. They talk about the profession's apparent loss of vision. This is our dental educators who are writing about this. Profession's apparent loss of vision for taking care of the oral health needs of all components of society, and the resultant potential for marginalization of dentistry as a specialized healthcare service available only to the affluent. And I'm going to extend that thought to say, where do we fit within health science in general? So what is the future of dental profession in the context of healthcare? Let's just review a few critical points. Certainly, patients' general health can determine their ability to tolerate dental care. We're well aware of that, and our graduates have to be fully aware of why that's important before they begin procedures on patients who really are not good candidates. Systemic disease can modify the management of oral disease. Diabetes mellitus is something that I and certainly a number of people in this room have been very interested in, and this is a very good example of how systemic disease can modify oral disease, and I'll talk much more about that in just a few minutes. Oral infection is a risk factor for diseases and disorders at distant sites. That's also a reality. It's really changed the way we talk as a profession, changed our literature, changed the number of papers dealing with supposed dental topics in medical literature. Again, it's driving us, I think, more towards the biological side of that diagram. Fourth, the population is aging, and these older individuals are going to present, number one, with teeth, with more teeth, but also with an increased prevalence of chronic disease. How do we manage these patients? How do our students manage these patients? I'll take that as an endorsement of that there. And the fifth point I want to raise, which I think is really very important, dentists are considered primary health care providers, whether we acknowledge this or not. If you look in the medical literature about access to care and about primary health care services, quite often, and certainly so more recently, physicians, mostly physicians and certain public health individuals who are writing about this are including dentistry in primary health care. And I think this is a very important consideration. We don't talk about it as much ourselves, but I think we should begin. So let me give you a specific example. Patients with uncontrolled medical conditions cannot be successfully treated for oral disease without an understanding of their health history. And I'll give you an example again of something that I've worked on. Diabetes mellitus. And this is just a CDC data on prevalence of diabetes mellitus in the population by age. This would be the youngest age group, and here, as you can see, more recently, this has increased dramatically. So here's a case. This case does come from our clinics at Columbia, and I'm not shy about showing it to you, but it was brought to my attention by one of the postdoctoral students. Here's a patient who presents to the clinic. You can see there's certainly some inflammation present. There's a moderately advanced to advanced periodontitis. Again, you look at the tissue here. You look at the tissue here. And here's the palatal surface. We would have a sense that while this is periodontitis, perhaps that looks a little different than we might expect it to look. And here's just a lingual view of the lower anterior teeth. Again, you can see some suppuration here. You probably know where I'm headed with this. The patient had conservative therapy, including antibiotics, systemic antibiotics, yet periodontal abscesses were still present. And in fact, a faculty member then stepped in and said, I don't think this looks correct. Patient was sent for evaluation, ended up being a poorly controlled diabetic. And so clearly, continuing with therapy, be it surgery or what have you, periodontal surgery in a case like this, was dooming the dentist to failure because we didn't understand the systemic overlying problem. So we're asking the question, can dentists become more involved? Should they be more involved in the health of their patients? And what kind of activities should we be thinking about? Now, what I'm not saying here is that we should become physicians. What I am saying is let's deliver better patient care by understanding more about our patients, and in addition to that, helping our patients improve their own health. So let's take these sort of one by one. Assessing hypertension. We've been told for 40 years that we need to take blood pressures before the patients are treated be it privately or in dental school. I'm sure you do it here at the dental school, but in private practice, less than a quarter of dentists actually assess hypertension on a regular basis. Smoking cessation. 20% of American adults still smoke. Two of the major diseases we're concerned with, oral squamous cell carcinoma and periodontal disease, are directly linked to smoking. Shouldn't we be advocates for smoking cessation? Diabetes screening. Here we're pushing the envelope just a little bit, but in the case I showed you just a minute or two ago, we could have avoided a lot of discomfort for everyone had we understood that patient better before we began therapy. Should we be screening for diabetes? Obesity management, certainly linked very closely to diabetes, and who but a dentist, or who better than a dentist can deliver a nutrition message to a patient? We know about this. We're comfortable with talking about nutrition. Should we begin to think about obesity management? And then we can go on, and again, pushing the envelope more and more. identification of osteoporosis from dental radiographs. I've spoken to our colleagues in endocrinology about this. DEXA scan is still the standard, but we have panoramic radiographs. There's data in that panoramic radiograph that's not otherwise being removed or being taken out, and I think this is one way in which certainly people at risk, because there are some good studies now showing relationship between density on a panoramic film and, in fact, osteoporosis. Good studies showing that those are linked. We could be doing this. And of course, this last one is a sort of a no-brainer, identification of suspicious dermatological lesions. I could have made this list even longer, but I think it's good to stay a little bit more narrow. So here's an example of what we're doing at Columbia. We feel that tobacco cessation should be part of what every dentist does every single day for those patients that require it. So as a result, we looked at what was available, what teaching and learning modules were available, and we weren't happy with those, so some of our faculty have created their own. So this is an online resource tool or resource that starts with simply a welcome with an understanding of how we're going to go about doing this, how we're going to be training you. I'm just going to show you a couple of screenshots. There's some background on nicotine physiology, what nicotine does, so that again, the user, the person who's going to implement this in the clinic will be familiar with this. There are resources of various sorts, including videos embedded within the learning program that could teach dentists how to interact with their patients, because this isn't something that there's a comfort zone with, but I think that's something that's really quite important. There's information about the kinds of medication that you would use. In this case, it's the patch. What is it? How does it work? And in addition to that, and I think this is really the key, there's some very simple algorithms that say if your patient smokes this amount, 1 pack or 2 packs, what are the combination therapies that you can consider? I'm not trivializing this. I know some of the drugs that have been advocated for use in smoking, such as Chantix, come along with some serious side effects. But we can do this, and I think we should be doing it because we're going to be seeing our patients on a more regular basis than they're seen by their physician. And just let me show you 2 examples of lesions that we saw in the dental clinic. Here's one. And you can see this is an ulcerated lesion on the temple. The biopsy showed nodular basal cell carcinoma. And here's another lesion that was picked up on the posterior helix of the ear, and that was an invasive melanoma. We should be looking, and if need be, we should be referring. So to put this into play in a grander way, we've started a clinical trial in our clinic that looks to determine, or seeks to determine, can we in fact identify undiagnosed, not poorly managed, but undiagnosed diabetes mellitus in the dental setting. So we want to develop and evaluate a target screening protocol for patients who are seeking oral health care behavior. I'll show you just a couple of those slides. Let me talk about the relevance here and the rationale. Why is this important? Well, we know that about 10% of the US population has diabetes mellitus by the latest definition, 25% of that group. So 2.5% are undiagnosed. We know that the complications of diabetes mellitus are significant, whether it's cardiovascular disease or nephropathy or retinopathy. They're associated with significant morbidity and mortality. We also know that the earlier you diagnose diabetes mellitus and you get a patient into care, the better our outcome will be in terms of reduction of complications. Patients with diabetes mellitus we know have oral complications. Oral complications of diabetes mellitus occur early. We did a study, a series of studies in the early part of this decade looking at children and adolescents and found that they were showing changes in terms of attachment level, because periodontal disease is the best identified complication of diabetes mellitus in terms of the oral cavity. And we saw kids as young as 6 or 8 years old who were beginning to show attachment loss, subtle attachment loss, but attachment loss nevertheless, before they were showing any changes in the eye or the kidney. And certainly, as I showed you before, and as you're well aware, successful dental care for a patient with diabetes mellitus requires good metabolic control. Try treating a patient who's poorly controlled. The patient will look just the same as they came in within 6 months or so. So what we did is we started a relatively simple trial with an intent to gather a lot of data. We looked at all patients who either, if they were over 40 years of age, if they were non-Hispanic white, or over 30 years of age if they were Hispanic or non-white, and they simply had never been told that they did not have diabetes mellitus. We asked them, would you agree to participate in a trial that included a chairside HbA1c, so a point of care HbA1c, and then come back later for a fasting plasma glucose, because that was a definitive diagnosis. 89% of these individuals, I may point out, had one of the self-reported risk factors for diabetes mellitus that are listed here: a family history, hypertension, high cholesterol, or being overweight. Those patients then continued in the study. They had their HbA1c done chairside, and then we took a complete history, medical history, as well as a complete oral examination. And 96% of those that qualified, in fact, have returned to date. 96% have returned for the second appointment. So that was a second appointment. They had to come back. They didn't come to the dental school. They went to the medical laboratory in the hospital for this fasting plasma glucose. And what did we find? Well, for the 600 patients, we found that 4.2% of those were identified with diabetes mellitus, frank diabetes mellitus. That should have been 2.5%. 32% were identified with prediabetes. This is the truly reversible pre-stage of diabetes mellitus. That number we would have expected to have been about 20%. We've done another 200 patients in a somewhat different protocol where we're using a laboratory HbA1c as the diagnostic, and in fact this number is approaching 5.5%. So what we're going to do is take all the data that we've collected, all of the health history data, all of the dental data, and we're going to then create an algorithm that will allow us to filter down and increase our yield. Right now our yield is roughly 5%. We think we can probably increase that to about 15%. What is good about this is I think it's captured the imagination of the dental students who see these patients being tested in the triage area, but the high percentage of individuals who are willing to participate both immediately and then come back, I think is an indication that we're looking at an area that, or we're proposing something that's not that foreign, not that strange, certainly to patients who would benefit from it. But let's talk about this whole idea of blurring of the borders between what's traditionally considered to be dentistry and medicine. Let me give you a couple of examples. First, pediatricians are able to provide and receive compensation preventive oral health care services. And I believe that's in 42 of the 50 states will compensate a pediatrician for topical fluoride and the like. That troubles some dental people. It troubles some people in state dental associations, but I kind of look at this as a two-way street. Here's another interesting, this is just a piece that appeared in the New York Times back a little more than a year ago, about a year and a half ago. This is a story about the emergency room physicians being trained to remove teeth in rural Maine because no dentist was available. And here you can see emergency room physician, I think she was a resident, giving a inferior alveolar injection to a patient, and she should actually be looking at the patient, but she's not. That's what 4 years of dental school will get you. But this concerns some people. This concerns some people, and I wonder if anyone in this room is concerned. But let's talk about the other side of that. Here's an advertisement that I pulled out of one of the throwaways. This is for something called the oral risk HPV test, where you'd actually use saliva to test for HPV, because HPV 16 and 18, the strains 16 and 18, have been linked to oral cancer. We're going to have to start thinking about these sorts of things. Our graduates are going to have to start thinking about these sorts of things in the future. And lastly, and I'll not comment at all about this, I will just show it to you. I received this in the mail not too long ago, where I could take advanced and updated Botox and injectable filler course should I choose to. Well, here we're getting into a realm that, again, is pushing the boundaries of what is dentistry, though I will make no comment. So what happens if we do this? What happens if we do this? I think the result will be, quite obviously, improved health and not just oral health. I think our results, our outcomes will be better, but I think the patients will be better as well. Just to sort of editorialize for a second, when we've talked to our colleagues in medicine and public health and nursing about this, they've been more than supportive. Because I think there's generally a realization that in traditional health care, primary health care is not done very well in this country. If we're 80% generalists in our profession, Medicine is about 20% generalists. They don't have everybody is subspecialized. The family doctor, if you will, is really something of the past. So this is an opportunity for us, not just to play physician. That's not what I'm talking about here, but to actually make what we do more interesting, more exciting, and the outcomes even better. How do we accomplish this? And this is, I go into this, and I'm sure you do as well, with the idea that it's not going to be simple. Certainly curricular revision is part of that, and whether it's the track concept that Peter has been talking about, that you're now in the process of implementing to make a better practitioner, that's great. We at Columbia also have a new curriculum, as I mentioned, and that curriculum is really focused on making our oral healthcare providers who are focused on the oral cavity. Do we have to think about accreditation? For those of us that go through this every 7 years, and I think there's a biblical connotation associated with this, perhaps so. But there may be willingness on the part of the accrediting body to listen to more of this. We feel that in order to develop these new types of providers, a mandatory PGY1 is essential. And this is, I don't know how important an issue this is in Michigan. In New York, as you may know, the state legislature, working with the dental schools, has passed a law requiring a PGY1 prior to practice in New York State. I think that was a major step. In our school, 98% of the students take a PGY1, at least a PGY1. And lastly, and I'm not going to get into this topic today, in order to do this, to be able to provide more care to the more difficult to manage patients, do we need to think about mid-level providers, also known as practice extenders? And this is extremely controversial, as you know, and Minnesota, perhaps nearby, is the best example of how controversial that can be. So let me close with a quote, and I know this is a lot of words, but I think it's important. Whenever you think you have a unique idea, you should always think twice about this. So I want to read this to you, and it is a lot, but bear with me. In this view of an enlarged dentistry, its practitioners would be trained to give the service not only of dental surgeons, as at present, but of oral physicians as well. Instead of examining only the teeth and mouth of a patient, they would also suitably inquire into and keep careful records of the state of the patient's health, particularly as it affects or is modified by conditions of the teeth and mouth. Dentists would recognize and note the significance of outstanding symptoms of systemic disease and warn or advise the patient accordingly. The frequency with which dentists are consulted for oral health services, now think about that, they're coming back twice a year, every 6 months, gives them special opportunity and an occasion to note not only the occurrence of oral and systemic diseases, but also the existence of correlations between them, and to help guide patients accordingly. So again, you think you have a new idea and you realized somebody 85 years ago, William Guise, in his report on dental education in the United States and Canada, said exactly this so many, many years ago. I think it's worth thinking about and worth considering because, and this is my final slide, the future of our profession is in your hands. So thank you for listening. I'll be happy to take some questions.